Good evening, guys. Welcome to this NEET PG Live Daily, yet another session. As I am discussing about drugs affecting, or drugs related to endocrinology system. So this is the 9th lecture in that series. Today I am beginning a new topic that is related to mainly parathyroid gland. So this topic has been named as drug affecting bone mineral homeostasis, drugs and hormones both, you can say. We have drugs available with us. We have recombinant hormones or their analogs available with us that can affect bone mineral homeostasis, that is mainly the calcium and phosphorus balance, mineralization of the bone, treatment for osteoporosis, etc. Hyperparathyroidism, hypoparathyroidism, like this, rickets, osteomalacia, all this thing. So guys, let us start with those who are actually attending my lecture for the first time. Let me introduce myself, that I am Dr. Pramod Sharma. I am a clinical pharmacologist by super specialty, and I have done my MD. That is only possible if you join this group, be part of this group. And actually what happens on this group, the Unacademy guys or the educator keep sending notifications regarding the timing of the class, the topic to be discussed and all that. So you will have information beforehand. That is always good to have timetable before before deciding or planning any activity. So that way it would be highly useful for you. So this is not the time to think over it. Just get it and join this group as early as possible. But let me clarify you that this is a one-way communication system, because this has been designed in such a way that you can only receive message, you cannot send message to us on this particular platform, right? The Unacademy has a subscription based platform that is called Plus for all PG aspirants, those who are preparing for medical PG entrance examination. So this platform has a lot many things to offer to its subscribers, because it would definitely have things or ingredient which a PG aspirant actually need nowadays, and that in the form of like you are attending live class just like this. But here on Plus you have lot many opportunities to have live interaction with your educator. So the reason being why it is has been made like this, because any learning process will only be fruitful or will give maximum efficiency or provide the maximum clarification to the learner from the educator side only when there is a real-time communication. That is why there is always a provision of physical class, not on, but because of this unprecedented pandemic, the people are on online. Otherwise teaching is always face-to-face interaction. So but the Unacademy has tried to cut down this inhibitions of or this limitations of this physical classes by allowing as much as possible physical this live interaction with the educator. And because the learners on Plus are less, that is why this is important, because the educator can pay full attention to the each and every learner, he or can focus on their difficulties or any certain weak areas that can be addressed in a much better way if educator is well aware of, and that is possible if there is cross interaction between the learner and the educator. Other than that, we have facility of live polls and leaderboard, because this live poll, through this you can always forward your concerns, your any creative idea. If you have any problem or or you want to appreciate some any lecture or any educator, kind of you can give both creative as well as if you have noticed something which is not appropriate or is having some issues, you can always share that also, because this platform is not for sharing good things. You can always point out if there are any negative or some defect is there. Leaderboard will give you an idea that where exactly you stand among your peers, so this keeps you moving and give you a fair idea about where about your or it assesses you in a fair way. It gives you an idea, and this is always useful for the educator as well, because the educator also comes to know that where exactly group is heading to and where the educator need to focus in which area this group is actually not performing well. So this is all is provided on this platform. There if you wanna have study materials, so there is no ample of study material is available on this platform in the form of test series, in the form of quizzes, their analysis and all. So you will never feel any paucity of this literature or the study material available on this platform. Also on this plus, we have provision of a live doubt clearing session that every educator is supposed to take after every 3 lessons that are completed on plus by that particular educator, because if any doubt the student has, that can be cleared in the class itself. But what happens many times, student is not that prepared. He goes back and reads something and come across some new thing or something which he is not able to decipher, then he can always come back to the educator in the doubt clearing session, and each and every issues of every learner, if they have, can always be taken up and resolved to their satisfaction. So this actually paid platform has all the ingredients which can justify or you can fulfill all your needs, because the Unacademy is the best learning platform in this country right now, and it knows the requirement of each and every aspirant of each and every competition, and accordingly this portal has been created keeping in mind those requirements, so that our learners get everything. They are not actually has to go somewhere else to find out something which is not available here. So this is a full package and means all the services under one roof, means one subscription with all unlimited access. The offline access is great. You can download anything any number of times you like, and the advantage is that you can always go offline and watch those live sessions, or can read these notes in the form of slides and all that. So there is not a problem with all these things, offline access. These are all rates for different duration of subscription that is being offered by the Unacademy as plus. So it varies from 1 month to 24 months, and the rates are accordingly varying, but the 4 month is cheapest if you consider per month cost, if you come down to the per month cost wise basis. But you can always avail the 10% discount on this, provided you fill this blank space with the referral code of the educator. For example, mine is Dr. Pramod. If you use this code, you will get 10% discount, right? So don't forget to fill in these details. And this is the rates after the application of 10% discount. Let me remind you once again that those who actually subscribe for more than or equal to 6 months, they can always avail the no cost EMI facility, which is an easier way of paying, because you don't have to pay the entire amount up front, and you can divide it in different many installment, and that will not be make not much hole in your pocket. So that way the Unacademy has also eased out this payment system. We have 1 to 24 period, months of subscription period, but we mostly recommend these 2 periods because this 12 month is important for all those who have already completed their MBBS and going to appear for the entrance examination. They have one year of time. By the time they finish this Unacademy subscription this course, and he will be ready for his entrance and all that. Or those who have already tried once or twice on this PG entrance but couldn't succeed. But we always pray that if you come on this platform, make use of it and try with the wholeheartedly with better preparation, and that would be definitely there if you could join plus. So high likely chances that you might crack that examination. Okay, so 12 month is for them because it would take time to cover up entire syllabus. How voluminous the syllabus is in all the subjects to be taught by the specialty from different field, and it will take time to get you also take time to get accustomed with or familiar with the this platform, and also learn from different educators, because it is not easy to judge anybody by a single point contact. You have to be with them, and trust us, you will never be disheartened by the quality of the content we offer, and the classes that are delivered are well up to the mark. And we keep posting different type of courses on this NEET PG Plus, which are actually floated as per the need of these learners, because different type of you will see different type of courses are available. You will have ample opportunity and you will attend many of such courses during this 12-month period. That is going to make you a better learner. So that is why you always recommend at least 12 months you should be associated with a plus at least. 24 month is good for those who are UG students and they are geared up for the PG preparation from right now, so they can always vouch for this 24-month subscription, because this is the cheapest one which can be offered by Unacademy to them. And by the time they come, by the time they get an opportunity to appear in face a PG examination, and so they will be in much better shape than to take up that examination. And not only this will help them also to score better in their university examination also. So guys, don't forget to apply this code, because as I said, you will get 10% discount. So bachcho, this for 24 months, otherwise this cost is 40,000, but after 10% discount you have 36,000 to pay only. Similarly, for 12 months the price drastically comes down to 24,750 instead of 22,7500, and you can pay by any digital mode whichever you feel is convenient for you or you have the facility of. So this was all about the subscription, because I would suggest that once you get attached to this or get associated with us and then feel the difference, because just standing away and commenting on something would not be right, because unless until you taste it, you yourself taste it, that then you can tell whether it is really tasty or not. If somebody else, don't go on somebody else's perception or comments or advice. You yourself actually assess it. So guys, let us start with the topic, the drugs affecting bone mineral homeostasis. You can see this diagram is the simplest diagram I have got to explain you thing. First of all, if we are talking about bone mineral metabolism, means we are talking about calcium and phosphate metabolism in the body. We are talking about thyroid gland in the body. We are talking about bones in the body. These are the things which I wanted to make it clear. We are talking about kidney in the kidney, because in the body, because these all are intricately related to each other and help in maintaining bone mineral homeostasis. Let us see. First, start from the gut. Whatever calcium and phosphate is present in the phosphorus is present in the dietary calcium or phosphate, or as a supplement that is being absorbed from the intestine under the influence of this is vitamin D3. not only vitamin D3, this is active vitamin D3, that is calcitriol, right? Vitamin D3 is something, activated vitamin D3, this is 125 dihydroxy cholecalciferol, that is activated vitamin 3, calcitriol. Otherwise vitamin D3 is simply the vitamin D3 that is naturally present from animal sources. Vitamin D2 is from plant sources, right? And this gets activated by hydroxylation at 1 and 25 position, then it becomes calcitriol, means activated vitamin D. So this promote this absorption of all these calcium and phosphate from the intestine, can maintain calcium level in the blood. Moreover, this vitamin D3 can also lead to deposition of the calcium in the bone and phosphate, and similarly it can also remove some calcium in bone. It may have some resorption property, but less than this PTH. This action is can deposit and can also resorption of can resorb the calcium from the bone. Other than that, vitamin D3, it is actually activated by, it requires two steps. One step is the 25 hydroxylation that occurs in the liver, and the final step in activation is this 1 alpha position, that is hydroxylation at 1 alpha position occurs in the kidney. That is why kidney has been shown here, and that is actually promoted by the PTH. PTH is stimulator of this reaction, and the fibroblast growth factor 23 inhibits this pathway. Actually this inhibits conversion of this vitamin D to its active form. Other than that, we have other hormones like parathyroid hormone release parathyroid. This parathyroid secretion is usually under the control of extracellular calcium levels that will decide inhibit, but this 120 dihydroxy cholecalciferol can prevent this PTH synthesis and release as the genetic level. It inhibits PTH release, and other than this, PTH is also acting on the bones and can release calcium from the bone, and it is important in maintaining serum calcium level. Immediate regulation of the calcium in the blood if there is any kind of problem. And we have other hormone also, calcitonin, that is released from the thyroid gland. This calcitonin as such has a role in decreasing plasma calcium level, and that is possible by its effect on the kidney, that I will tell you. So it prevent this bone resorption. First of all, that is one of the way it can reduce serum calcium level, and another is on the kidney, that I will be discussing. So this is the simplest diagram to understand what exactly actually is going on, how this bone mineral homeostasis is maintained. This is the simplest diagram. Now we'll move to little bit of this informative content, and then again there will be few diagrams, then I will make everything very clear to you. All right. Usually the average diet of an American, we don't have data actually, because all the textbooks and all that are actually written by, good textbooks are written by Western world, and they have information from their own community. So usually an average diet, it may be much less in Indians, is containing 600 to 1000 milligram of elemental calcium per day, of which only 100 to 250 milligram is absorbed. This is called net absorption. Why I am calling it net absorption? Why? Because it is absorbed in the duodenum and upper jejunum, but part of it is also secreted in ileum. So here it is absorbed, and there it is secreted. So there is loss also. So the net absorption is around 100 to 250 milligram. Phosphorus, if we talk about, that is also present on an average similar amount, but its absorption is greater than the calcium. Why? Because in calcium there is loss also, secretion is also. Here it is only absorption that mainly occurs in the jejunum. Got my point? When in steady state, this is in a steady state, when everything is came within the on equilibrium and all that, this renal excretion actually balances the intestinal absorption. Why? Because if it is excess is absorbed, excess will be excreted from the kidney, and the plasma concentration of these are maintained well within the tight regulated limits. Usually the whatever filtered calcium is there from glomerulus is 98% of it is absorbed, and 85% of the phosphate is also reabsorbed. There are certain conditions where there will be phosphate loss, phosphaturia, like Fanconi syndrome, etc. That is the different thing. The movement of this calcium and phosphate is closely regulated because it is closely regulated at the level of intestinal epithelium, from where it is actually absorbed, and renal tubular epithelium, because here it is excreted if it is more, So movement of calcium and phosphate closely regulated at two sites. So both the sites are important because there may be any impairment in the function of these sites. For example, intestinal epithelium, malabsorption like tropical sprue, renal tubular epithelium defect may be in the form of renal failure, etc. So this actually, the regulation is disrupted, and it can very severely affect the the bone mineral homeostasis in the body. Now I'm going to talk something important, which is a little away from the normal concept what people have. This called calcium and phosphate in the body is regulated primarily by the three hormones. But as per the belief, you don't find calcitonin here. Calcitonin role is less critical. It is mainly by the parathyroid hormone, which is related from the parathyroid gland. Fibroblast growth factor 23. It is produced by many cells, especially in the bones. Under the influence of vitamin D, fibroblast growth factor is released. And this vitamin D, especially this active form calcitriol. It is said that the role of calcitonin is less critical in physiological control of calcium and phosphate level in the body, but it becomes its role is little greater at the time of pregnancy and lactation. But definitely the pharmacological doses of calcitonin, again remind you, pharmacological doses are something different, which are different from the physiological amount that is being secreted in the body or required for the physiological effect. Pharmacological doses are always higher than that. So pharmacological doses of calcitonin have important effect on the serum calcium level, that it reduces serum calcium level. That is why it is used in malignant hypercalcemia and all that. So it is done by it first actually reduces inhibits resorption of the bone from where the calcium is released, and also it promotes the renal excretion of phosphorus and calcium. Increases renal excretion, thereby reducing the serum calcium level. So role of calcitonin, as per the natural belief, this has not been considered as the important hormone in controlling the or regulating the physiological calcium and phosphate concentrations, right? Again, there is a diagram. Let's see how these hormones affect the calcium and phosphate release. Just remember, the vitamin D actually reabsorbs both the phosphate as well as the calcium. Calcitonin excretes both, promotes excretion of calcium and phosphorus both. Parathyroid inhibit excretion of calcium but promote reabsorption of phosphate, right? And FGF23 only has effect on phosphate. It promotes excretion of the phosphate, and in fact raised phosphate promotes release of the FG23. Raised this thing, low level of vitamin D3, that also can promote fibroblast growth. So all these are factors that actually leads to increased vitamin D3 actually promotes fibroblast growth factor 23. This is the, you can see this fibroblast growth factor D. I was telling that the vitamin D3 in activated form actually promotes FGF23 promotion as well as the phosphorus, raised phosphorus, and it is inhibited by dentin matrix protein, and here you can see the increased calcium and vitamin D. Increased calcium, as I already told you, that calcium, the PTH secretion is regulated by the extracellular calcium level. If calcium is increased through calcium sensing receptor, it can inhibit parathyroid hormone level. And I already told you that vitamin D inhibit PTH, that is on the genetic level. It actually gets converted to vitamin D3 inside the PTH. There is an enzyme called CYP27B1, which is also known as alpha-1 hydroxylase. So that is present in the kidney, same. So this vitamin D3 can prevent PTH secretion. PTH promotes, vitamin D3 is inhibiting PTH, but PTH is supporting vitamin D by converting into dihydroxylated form, which is an active form, calcitriol. This is calcifediol to calcitriol. And phosphate, as I said, phosphate is promoting FGF23. You can see here FGF23 release, and as well as phosphate is promoting PTH also, because PTH is actually increases calcium reabsorption in the kidney but decreases reabsorption of phosphate, loss of phosphate. So if phosphate is increasing, that will promote PTH production so that phosphate can be removed through the kidney. Okay, so I don't think there should be any issue. You must have understood by now that what is controlling what. Calcium and phosphorus are absorbed under the influence of the vitamin D from the intestine. Vitamin D is promoted by PTH. PTH stimulates vitamin D conversion into active form. Vitamin D promote release of FGF23, but FGF23 inhibit vitamin D3 conversion. Okay, so you just see this thing. Okay, one is helping and PTH stimulates vitamin D3, but vitamin D3 inhibit PTH. Vitamin D3 stimulate FGF23, but FGF23 inhibit vitamin D. You can see this is very tightly and very very meticulously regulated system, right? This FGF23 is released by the osteocyte cells, right? Osteocytes are actually nothing. These osteoblast cells are first pre-osteoblast. They are converted into osteoblast, which is active bone laying cells. Once they lose capacity to lay new bones, they are converted into lining cells. And some of the cells get into buried into the bone matrix. They are called osteocytes, but they are not dead cells. The osteocytes are active. They are in connection with other also. They can provide they have connection between cells and all that, so they have active role. They are not died and buried cells. They are active cells. So they are secreting FGF23. This FGF23, how does it act in the kidney? I said it promotes phosphate loss. Actually, it promotes phosphate excretion, and you can see how it can done. It actually inhibit the sodium phosphate co-transporter 2A and 2C. 2A and 2C subtypes are important in the kidney. They are present in the kidney. Okay, so thereby it reduces inorganic phosphate reabsorption, so more phosphate is lost, right? FG23, I told you, it acts on this hormone, which enzyme CYP27B1, which is which converts monohydroxycholecalciferol to dihydroxycholecalciferol. That is in 125D form. The 25 form is converted into 125 hydroxy, so this is converted to 125, so its activity is reduced, so it is actually in reducing activity of the vitamin D3. Another, it is promoting the activity of another enzyme that is called CYP24A1, which converts CYP25 to 2425 dihydroxy vitamin D3. This 2425 C calciferol, its level is increased, right? You can see that because of the decrease in vitamin D3, there is a decrease in all those sodium phosphate, organic phosphate co-transporter 2B, which is important in kidney. Intestine. So in intestine, you can see this 2B, this is reduced, so there is less absorption of the phosphate from the intestine also. So it is promoting release excretion through the kidney and inhibiting also absorption through the small intestine. So thereby altogether it reduces serum phosphate level, right? This is the mechanism by which it actually acts. It is released from the syncytium. So the important stimulus for its release are the phosphate level, the increased phosphate, or the vitamin D, active vitamin D3. They all actually stimulate FGF23 production, right? What are the different calcium preparation which we can use clinically? There are many, but some cannot be used. This calcium lactate is a very good preparation which can be given. All are can be given orally except calcium gluconate, that can also be given parenterally. This is non-irritating, well tolerated. Very important thing is it should be non-irritating and should be bioavailable as well. Calcium dibasic phosphate these are percentage are elemental calcium which this salt contains. This is salt. This salt may weigh 100 milligrams suppose, but it will contain only 13 milligram of calcium. That is the meaning of elemental calcium. So calcium dibasic phosphate has 23% of elemental iron. The problem is that it is insoluble in water, but it is very well solubilized in the presence of gastric acid. So those individuals who are using proton pump inhibitor or H2 receptor antagonist, the viability is less in those individuals. Calcium gluconate, though it contains less elemental calcium, but it is non-irritating to GIT as well as vascular endothelium. Why I am talking about vascular endothelium? Because it can be injected IV also. It's available as 10% injection, right? 10% means 100 ml of it will be having 90 milligram of this 900 milligram of this. So this non-irritating to GIT as well, and with the moment you give it as moment you give it as IV, it produces a sense of warmth, in fact, so this sometimes used in many cases of tetany, etc., where emergency calcium salt is to be given. Calcium carbonate is the most commonly used this salt. It has 40% of elemental iron, and it is problem is that is poorly soluble in this gastric acid. Poorly soluble, so that is why it requires gastric acid to solubilize it to make it available in the soluble form so that it can be absorbed. So its viability is less in individual who have less acidity, gastric acidity, for example elderly, and those who are using PPIs or H2 antagonist. Calcium citrate, it is slightly soluble in water, but is very good solubility in presence of gastric acid. But even if patients are using PPIs or H2 antagonist, its bioavailability is adequate, or in elderly it provides sufficient calcium because that slight solubility is sufficient to make it absorbable. Calcium chloride, though it has 27% of elemental, but it is freely soluble but it is not used because it is highly irritant to gastric mucosa and other tissue. Irritant, highly irritant. So these are the salts available. Most commonly used: calcium carbonate, calcium lactate, etc., calcium citrate. So what are the clinical uses of these calcium salts? First of all, they are to be used as dietary supplement. When it is required as dietary supplement, growing children, the pregnancy, lactation, postmenopausal women, right? These all individuals should receive it as a dietary supplement. Also used in tetany, especially in severe case where this we need to have this parenteral calcium gluconate needs to be given, just 10 to 20 ml of calcium gluconate IV. It is a 10% solution. No, it contains 9% elemental iron, suppose, right? So this 10 to 20 ml contains 90 to 180 milligram of calcium, and it is to be given immediately over 10 minutes, followed by you can again use you may require 50 to 100 ml of this calcium gluconate need to be given over 6-hour infusion. So your 52 means you are 450 to 900 milligram of additional calcium may be required over 6 hours period. But if it has been once this episode is controlled, we need to ensure that long-term oral treatment with calcium daily with vitamin D3 to ensure its proper absorption as well, because the patient might be deficient in vitamin D3 as well. And the mild case of tetany may be treated only with oral calcium. Mild cases, you don't have to give it parenterally, oral calcium only. Osteoporosis, yes, calcium and vitamin D3 actually are used in the prevention and treatment of osteoporosis, along with other primary therapies, which are primary therapies of osteoporosis. For example, hormone replacement therapy that it contains estrogen, bisphosphonate, or this PTH or Raloxifene, etc. This SERMs, all SERMs are not approved. Raloxifene is used, and other is the bajedoxifene is also available. So these are used along with these, so that to make it sure that there is no deficiency of calcium occurs during the treatment with these primary therapies. So they have kind of adjunctive role in osteoporosis, and as such the ability of calcium and vitamin D3 alone to improve bone mineral density, etc. in osteoporosis is controversial. And also these calcium salt can be used as antacid. Calcium carbonate is used as antacid. Focus on this diagram. It has lot of things again to have added many information in this particular diagram, for your understanding. We know the vitamin D is synthesized in the skin, and that is why it is advised to give adequate sun exposure, because India is an country where there is no dearth of sunshine and all that. So the ultraviolet B rays that falls on the skin converts the 7-dehydrocholesterol, which is the ingredient for synthesis of vitamin D. So this vitamin D is called cholecalciferol. This is natural vitamin D, and vitamin D obtained through food like egg or these supplements in the tablet form or this animal material. And vitamin D, another is ergocalciferol, which is plant derived. So plant derived especially comes from mushroom. mushroom is not that mushroom which is grown in or farming is done, because that mushroom is grown in dark actually. The mushroom which is wild mushroom, that grows in sunlight, that mushroom contains vitamin D actually. And this animal source vitamin D3 is also important. It is available in egg, suppose, so it is available in higher quantity in those eggs. The means when the hen is more exposed to sunlight, a hen exposed more to sunlight than the another hen which is less exposed, that egg will contain more vitamin D. That is why the broiler, this egg from the farmhouse, and that is from natural from the which is from the wild type hen has difference in this vitamin D quantity. So more hen is exposed to sunlight has higher vitamin D content. This vitamin D, once reaches to the blood, is carried or transported by vitamin D binding protein. And this vitamin D binding protein has a high affinity for this natural vitamin than the different analog of vitamin D, right? And it reaches to the liver, where this cytochrome enzyme 2R1, which actually leads to 25 hydroxylation. Add hydroxyl group at 25th position of the vitamin D, and after that this is called as calcifidiol, which reaches to the kidney, which is converted by 1-alpha hydroxylase, which is known as CYP27B1. This converts this vitamin D3 to calcitriol, which is an active form and major circulating form. Calcitriol, 120 dihydroxy cholecalciferol. Okay, cholecalciferol. This is 25 monohydroxy cholecalciferol. This is simply cholecalciferol. This is a plant and ergocalciferol, or you can call them only calciferol also, vitamin D2. And how it is actually metabolized? This is metabolized by an enzyme CYP3A4, converted into these red one are inactive metabolites, right? So this vitamin D, this monohydroxy form is also converted into 24R and 25 dihydroxy vitamin D cholecalciferol. This is known as calciferol. Earlier it was known to be inactive compound. Now it has been found that no, this is not inactive, this is active actually. This binds to its receptor present on the site of fracture site in a fractured wound, which is known as FAM57B2, that is family with sequence similarity 57B isoform 2. Binds with this, leads to production of lacquer, that is lactosyl ceramide. This lactosyl ceramide is important for, means this interaction of this calciferol with this receptor is important for production of lactosyl ceramide, and thus in the callus and healing of fracture. So this in the callus, this lactosyl ceramide is formed, and this is important for healing of the fracture. So this is not at all inactive, this is active form now, right? Considered as active. Moreover, there are sometimes some mutation in this CYP3A4 that is called gain of function mutation. Gain of function means the CYP3A4 becomes more functional. So this actually leads to rapid breakdown of this vitamin active calcitriol, and this may produce rickets in children, early rickets. It can present certain case reports have been there in the literature that such patient can produce with very early rickets in the childhood. So all these things you have understood, see, and this enzyme is inhibited by FG23 because this is converting vitamin D into active form. So this is inhibited by FGF23. Whereas 125, this vitamin actually stimulate FG23 production, FGF23, but it is inhibiting. And PTH also, PTH is stimulating this conversion. Vitamin D is converted into active form, but vitamin D inhibits PTH. Calcium also inhibit, and vitamin D3 at the genetic control within the PTH, it inhibits this PTH because this enzyme is present in the PTH also. So in the not PTH, in the parathyroid gland, where it is converted into active D3, and this binds with the nuclear receptors and can lead to because these receptors are present in the parathyroid gland as well. So this picture gives you entire idea. I told you what is the natural form, what is cholecalciferol, what is cholecalciferol or ergocalciferol, and how it is get converted. This cholecalciferol is not an active form. If you find in any tablet that it contains vitamin D3 this much, it means it is not active. It has to get activated like this, going in the liver and in the kidney. This is the active form, most active form, calcitriol. So I have added everything for your convenience. Everything, this, and this, this, everything I have added for your convenience. This, okay. Both natural vitamin D is present in diet, as I said, from the animal sources or the plant sources, all kind of, it is present in the diet. And but this calcitriol is the most potent stimulant for intestinal calcium and phosphate transport intestinal, and also may lead to bone resorption. I told you this calcitriol is the 1,25 dihydroxycholecalciferol. And first thing, this natural vitamin D is though present in the diet, both D2 and D3, but D3 is better absorbed. Remember this. So this calcitriol has most potent stimulant of intestinal calcium absorption, because this is the active form, obviously. And this may also lead to bone resorption. Vitamin D, usually PTH leads to, but this can also lead to bone resorption, because this has activity like, like PTH, it converts pre-osteoblast to mature osteoblasts. These are bone forming cells. So vitamin D is involved in bone forming also. Osteoblast produces a protein called RANKL, receptor activator for nuclear factor kappa B ligand, and also OPG, osteoprotegerine, right? I am telling you how it actually does. This rank ligand is actually acts on there are receptors, there are cells called osteoclast precursor that are converted into the mature osteoclast. That can be done by both the vitamin D as well as PTH. So what this is converted into, so it leads to proliferation and activation of this, and there are receptors that are called rank receptor on this precursor. So the rank ligand binds to this rank receptors, converted into osteoclast. This osteoclast actually gets recruited and activated to form attached to bone, and leads to digging of the bone and all that. So there actually leads to a resorption and bone. Okay, so indirectly this vitamin D is responsible for production of this rank ligand. Rank ligand affect this activity of osteoclast, etc. So this is indirectly leading to because vitamin D was causing pre-osteoblast to convert osteoblast, and also induce synthesis and production of rank ligand and OPG. OPG is the inhibitor of rank ligand. It can bind to this rank ligand. So this osteoblast actually controls the osteoclastic activity. Instead of binding this rank ligand to stimulate osteoclast, this osteoprotein produced by osteoblast can bind to rank ligand and inactivate. So this is tightly regulated, because whenever there is osteoclastic activity, resorption of bone, at that place new bone synthesis has to take place always. Remember this. So how does this calcitriol stimulate intestinal calcium and phosphate transport? This is actually by the action of this calcitriol that leads to induction of or production of new proteins, in intestinal epithelium. For that produces calbindin and TRPV6. Calbindin is nothing but vitamin D dependent calcium binding protein. And this TRP is transient receptor potential. It has many families. So subfamily vanilloid, member 6. This is a kind of epithelial calcium channel. And we saw the sodium phosphate co-transport B in the intestine, so that is also there. So through all this can promote, stimulate calcium and phosphate transport in the intestine. But in the kidney, it does not require production of any new protein, etc. It is just by the modulation of, it modulates the calcium flux in the kidney, both at the brush border and basolateral membrane. It is like this is the brush border and this is the basolateral. So whatever is absorbed from here, this will be taken in the blood from this basolateral membrane. This is the tubular luminal side of the tubular cells. Calcitriol can induce rankle, I told you already. So this rankle from the osteoblasts, so thereby this production of rankle can regulate osteoclastic activity. Got my point? And when there is osteoclastic activity, there is always new bone formation also takes place. Also it regulates the activity of the osteocalcin. Osteocalcin is produced by osteoblasts. And is osteocalcin, if you remember vitamin K, we were talking about this warfarin, etc. Vitamin K is important for gamma carboxylation of certain gamma carboxylation of terminal glutamate residues of certain clotting factors, and this protein was also there, osteocalcin. This osteocalcin in its carboxylated form, then it is, when glutamate residue is carboxylated, that becomes GLA residue. Glutamate carboxylated become GLA domain, or it called GLA domain containing protein. This GLA domain is actually increases the affinity of any protein towards the calcium. Clotting factors also, because of that, they develop very high affinity for calcium and all that. So this osteocalcin can directly bind to calcium, and can concentrate that calcium or concentrate their deposition in the bone. So the osteocalcin can be considered in its carboxylated form. It should be containing GLA domain, otherwise it will not be active, right? So this is, so that is why it is said that in bone metabolism, vitamin K also has role. Not only vitamin D, vitamin K may be also important for bone health, right? So this osteocalcin concentrate calcium in the bone, that is required in the bone, right? So you can take the osteocalcin activity as the marker of the new bone synthesis. The level of osteocalcin may be considered as a marker of new bone synthesis even. Other than that, it also regulates activity of ALP, that is alkaline phosphatase. You will be surprised that from where this alkaline phosphate, but you should know alkaline phosphatase is not related to only obstructive jaundice. In bone disorders, placenta also, this all release alkaline phosphatase. This alkaline phosphatase is a very important regulator of bone mineralization. Regulator of bone mineralization. See, now it is enhancing, this vitamin D enhances the activity of alkaline phosphatase. This alkaline phosphatase, what it does, it hydrolyzes pyrophosphate that is there in the bone. Pyrophosphate, inorganic pyrophosphate, that is in the bone. So it actually hydrolyzes this pyrophosphate, which is considered as the natural inhibitor of bone mineralization. After hydrolyzation of this inorganic pyrophosphate, actually organic phosphate is released. So you can understand, this was the actual inhibitor of the bone mineralization. It is hydrolyzed, so there is bone mineralization inhibition is attenuated. Further, as a end product you get organic phosphate also. This organic phosphate can be used for the mineralization of bone, that is formation of hydroxyapatite crystal. Hydroxyapatite, bone has two parts. One is mineral part, that is called hydroxyapatite, and that is one is protein part, that is called osteoid, right? So this osteocalcin is a non-collagenous protein, because usually much of collagen proteins are there in the bones itself, but this osteocalcin is non-collagenous protein also, remember this. Other than that, this vitamin D3 in the activate, this calcitriol, don't call it this calcitriol has direct inhibitory effect on PTH gene transcription. It affects at the transcription level, so this is within parathyroid is more important, because the secretion of PTH hormone is under the control of extracellular serum calcium level, because PTH gland has calcium sensing receptors. So this calcium acts on this. If this is high, this will sense it that the levels are high, this PTH secretion will be reduced. So this is negative feedback loop, right? Other than that, this can be affected at the gene level. This PTH level can be affected at gene transcription level by vitamin D3, because the PTH has vitamin D receptors also. This parathyroid gland has vitamin D receptors also, and vitamin D receptors, and the enzyme CYP27B1, which is 1-alpha hydroxylase, which is usually present in the kidney, which leads to hydroxylation at what position? So 25 monohydroxycholecalciferol enters this gland, where this enzyme is present, converts it into active form calcitriol, that actually interacts with the vitamin D receptors and affects the gene transcription and can inhibit the transcription of PTH gene. So this is important. So this is another negative feedback mechanism, another inhibitory control. So this within parathyroid hormone is more important, not circulating level of calcitriol is important. It is the within the gland which produces actually this active form of vitamin D is important, not the circulating form, right? It is also claimed for several, I told you last time in the corticosteroid also, that these many substances which acts through the this nuclear receptors, they can also, not only all the effects are produced through regulation or modulation of gene transcription, etc. There may be certain non-genomic effect or maybe a rapid effect that cannot be explained on the basis of genetic action, because that takes time. So most important non-genomic effect that has been demonstrated for vitamin D is that after the administration of vitamin D, that is calcitriol, not vitamin D3 simple, calcitriol, that is in active form, a rapid increase in intestinal calcium transport, rapid absorption, that has been demonstrated, and this is called transcaltachia. And this is not only occurs in, this has been demonstrated now in other tissues also. For example, fibroblast, keratinocyte, osteoblast, chondrocytes, etc. In these tissues also it has been demonstrated, and it was realized that there could be something present on the membrane which actually leads to such rapid response. So two receptors have been identified for these effects. For example, MARS, that is membrane associated rapid response steroid binding protein, and vitamin D receptors themselves, they are present on the membrane. These non-genomic effects are because of this, but these vitamin D receptors that are present on the membrane are activated by a special configuration of this calcitriol, that is 6S cis conformation, and 6S trans conformation is important for genetic effect. genomic effect. So this is the difference. So these receptors may be present in the cavule with caveolin-1 protein. Caveolin proteins are important for transport and etc. inside the cellular organelle transport here and there. So caveolin-1, and they are present. They may be co-localized in the cavule. A kind of pit is formed that is called cavule. So with the caveolin-1, they may be present in the cavule, and they can co-localize and can interact with each other also, right? And also the interaction between the membrane receptor and nuclear vitamin D receptor has also been proposed. This has been proposed for corticosteroid also, that may be a crosstalk between the membranous receptors, membrane close to the membrane because of pymetylation and all that, and the receptors which are present inside the nucleus or all that. There may be a crosstalk also. So that has similar mechanism has been proposed for this vitamin D receptors as well. Got my point? This is also called GRP52 receptor. This is the picture you can see. See, this is the cavule. This is the membranous VDR. This is Mars. I have told they can be co-localized, and they can activate many signaling cascade involving and can affect the activity of different channels, G protein coupled receptors, or many this tyrosine kinase receptors like SRC kinase, and stimulated by 125. This is calcitriol, and second messenger forms on many. This blue line indicates the non-genomic action. Here also you can see this is the non-genomic action degradation. Actually, this 25 form of this is monohydroxy. This also have some effect. It has been found to leads to breakdown of this gap. This SRE-BP, if you have attended my class of hypolipidemic drug, where this SRE-BP is very important, that is a steroid regulating element binding protein. Actually, it is important for production of cholesterol and all that, right? So this is actually associated to a protein which is called SRE-BP cleaving activating protein. This leads to a cleavage of this SRE-BP, escape protein. So 25D3 can lead to degradation of this scap without any genomic action. It is direct action in the endoplasmic reticulum. So it has been proposed that vitamin D is being explored for having hypolipidemic effect. Because of this can prevent steroid production, cholesterol production, and so hypolipidemic action is being explored for, because this particular monohydroxy form is capable of degrading this scap. This is the insulin induced gene INSIG. That is also a anchor protein present on the endoplasmic reticulum which hold this structure. So this is the example of membrane associated action of these, or rapid action or non-genomic action of vitamin D. Vitamin D, as I said, the both type of natural vitamin D is available in the diet, and that is absorbed through the bile salt, because these are fat soluble vitamins, so bile presence is must, and they are absorbed through lymphatics. And I told you this D3 is absorbed better than D2. The animal source D3 is better absorbed than D2. Steatoria, for any reason patient is having obstructive jaundice or anything, whatever the reason may be, patient is having high fat, or losing fat in the stool, or any kind of malabsorption syndrome will interfere with the absorption of vitamin D3. The vitamin D3 is stored in the body for months, especially because it's a fat soluble vitamin, so it is especially absorbed in the adipose tissues, not in the liver, mainly in this adipose tissues. Usually in normal subjects, the terminal half-life of calciferol, that is 25 hydroxy cholecalciferol. This 25 hydroxy, not dihydroxy. Similarly, the C-calciferol, 24-25 dihydrocholecalciferol. Calciferol has half-life similar to that, and in case of in anephric patient, this can be up to 6 weeks, 42 days. But in contrast to that, this calcitriol has high turnover rate, and it is cleared more rapidly, and its half-life can be measured in hours. And many analogs of vitamin D, calcitriol, etc., they have, they poorly bind to proteins, this vitamin D binding protein. So their action is, the half-life is very short, in minutes, and these analog may not have hypercalcemic effect. They do not cause hypercalcemia. And all the tissues have all organ, all tissue, all cells have VDR, this vitamin D receptors. So, and the target organ what we actually study is the kidney, the liver, the bones, and etc., and intestine, etc. So the analogs of these calcitriols, etc., are being made which do not have this hypercalcemic effect, where this hypercalcemic effect are separated from other effect. So they do not have hypercalcemic effect, but have other effects, beneficial effect on other tissue, required effect. Similar such is, I will talk about calcipotriene, that is used in plaque type psoriasis, which is non-hypercalcemic analog of vitamin D3, which actually produces anti-inflammatory and all that. It's useful in psoriasis, skin disease, plaque type psoriasis. So it is being, this has been tried many things. Vitamin D potential as a or their analog is being explored as a potential therapy for many of the ailments, etc. And metabolites of vitamin B2 are excreted mainly in bile because they are fat soluble vitamin, right? We have different preparation of vitamin D. We have already told you that this alpha calcidiol, the alpha name itself suggests that it has a calcidiol, means it is not double, it is not calcitriol, because it is hydroxylated 1 alpha position, which usually occurs as the second step. First step occurs at the 25 hydroxylation in the liver, followed by 1 hydroxylation in the kidney. But this alpha calcidiol is 1 alpha monohydroxy cholecalciferol. It is converted into calcitriol ultimately in the body. It is considered as a prodrug, and it is effective in all indications where calcitriol is actually needed. For example, any bone mineral disease, any bone disease, hypothyroidism, or this thing, what we call it, rickets, etc. Everywhere it is effective, alpha calcidiol, right? Where calcitriol can be used, there alpha calcidiol can be used. The example why we are using this alpha calcidiol, the purpose we should know. It can be given orally and equally effective as calcitriol. First, alpha calcidiol is required because when there is renal failure, so what will happen? This 1 alpha hydroxylation will suffer. So the active form of vitamin D3 will be reduced. Reduction in the 125 dihydroxy. So that also actually leads to reduce, inhibition of PTH, etc. That is why renal failure, secondary hyperthyroidism develop, parahyperthyroidism, hyperparathyroidism, secondary hyperparathyroidism develops because PTH is inhibited by vitamin D and all that. Vitamin D maintains calcium level. So calcium level is low, vitamin D is low, so all promotes PTH release. So there is secondary hyperparathyroidism. Then it ultimately leads to bone loss then, right? So it is equally effective. And one advantage is, even if kidneys failure, suppose patient has liver failure also, then how it will be activated? Because it is already activated at 1 alpha place, you require activation at 25 this active position, and this is carried out in liver. But good thing is that even if there is severe liver disease, this 25 hydroxylation is not compromised. This nature has given us some defense mechanism kind of thing. So once you start treatment with alpha calcidiols, you have to keep watch on the serum calcium level so that you can very well decide the actual level of maintenance dose, can decide the maintenance dose. And if sometimes the hypercalcemia occurs, then you can interrupt therapy for some days and again start. Dihydrotestosterone. This is a synthetic analog of D2, but it has greater efficiency in mobilizing calcium from the bone in comparison to vitamin D, other vitamin D. This is a synthetic analog actually, right? The reason being, it is used in hypothyroidism, so there is less PTH, so if it is already analog of vitamin D2, it does not require conversion into active form, because this is already also one hydroxylated at 1 alpha position, like alpha calcidiol. It requires activation in the liver. It is also a product kind of thing, activation in liver at 25 place, at position 25. But it is a synthetic analog of vitamin D2. Maybe that is the reason it has more or greater efficiency in mobilizing calcium from the bone in comparison to other vitamin D. So it is useful in hypothyroidism and can be given orally. This is the only difference. This is like alpha calcidiol, but only thing is that it is more capable of mobilizing calcium from the bone. Calciferol, same as ergocalciferol, जो plant derived, I was telling about that, or you can call it only calciferol, not a problem. Or it is also known as vitamin D2. It is usually available for oral preparation, as oral preparation only. It is available as solution in oil, and gelatin capsules are there. Oil like substances are filled in that are given in many supplementary when one has to supplement these vitamin to the malnourished children and all that by government agencies and all that. So these gelatin capsules are available. Cholecalciferol, as I saw it from the animal source, that is called D3. This is not active. This has to be converted into 25 and then 125. Then it will be. So it is available as granule for oral use and also available as oily solution for IM injection. This will act for longer time. And calcitriol is available both for parenteral use as well as oral use. It is a very potent substance, that is why it is used in micrograms. So you can use 0.25 to 1 microgram orally either per day or every other day. Other day means leaving one day in between, today and day after tomorrow. Or when it is given IV, it is always given every other day. So you got alpha calcidiol, dihydrotestosterone, calciferol, calcitriol. You have doxorcalciferol. There are many. These have recently made their appearance in the therapeutics of the doxorcalciferol is a vitamin D2 analog, similar to DHT, dihydrotestosterone. But the advantage with this doxorcalciferol is that it has all the, it is equally capable of suppressing PTH, but minimal hypercalcemic effect, with minimal hypercalcemia. This is the advantage of this doxorcalciferol. Got my point? This doxorcalciferol is also hydroxylated prior to but it is hydroxylated at 24 and 25th position. Got my point? It is very similar to say calciferol, that is also 24 and 25th dihydroxylation, but this is vitamin D2 analog. So it is used in the treatment of secondary hyperparathyroidism in patient with chronic kidney disease. These individuals actually develop secondary hyperparathyroidism. I told you simply because of reduced conversion of vitamin D in active form, because kidney is damaged. So there is increased Though there is no negative feedback inhibition of PTH will increase and all that. And also deficiency of vitamin D is also related to reduced calcium and all that, because the absorption from the intestine etc. is not there. So PTH level has to increase to maintain serum calcium level. Then it releases it from the bone. So there may be osteodystrophic, renal osteodystrophy we call it. When there is chronic renal disease, there may be osteodystrophic lesions also, because of the excess PTH activity, right? It can be given as peroral or intravenous. Pericalcitol is another compound which is available both as oral and IV, and it is also used in secondary hyperparathyroidism, and it is given in stage 5. Those patients who are having CKD of stage 5 finally requiring hemodialysis or peritoneal dialysis, CAPD, continuous ambulatory peritoneal dialysis. So in those patients it is to be used as a treatment, and those who have stage 3 or 4, in them it is to be used as to prevent secondary hyperthyroidism. They have still not developed secondary hyperparathyroidism, and in the stage 5 as a treatment. L-decalcitol is vitamin D3 analog. It is it is a strong inhibitor of bone resorption in the body, calcium resorption, and it has thus increases BMD, and it is actually used in Japan, only approved in Japan for the treatment of osteoporosis. Otherwise, as such, it is not approved as a treatment of osteoporosis in UK, US or European Union, but in Japan it is approved for the treatment of osteoporosis. L-decalcitol. Maxicalcitol, phenylalcitriol are also used for secondary hyperparathyroidism. They are all approved in Japan. Maxicalcitol and phenylalcitriol. What are the clinical uses of these vitamin D? So vitamin D is to be used both as prophylaxis and as treatment of nutritional deficiency. That is important use. So in the prophylaxis we usually use 400 international unit of vitamin D3, and in treatment we use 3,000 to 4,000 international unit of vitamin D3 for prevention of rickets in the children and or the osteomalacia in the adults. Okay, or you can alternatively give 3 to 6 lakhs unit of vitamin D3 cholecalciferol as a oil, or either you can give as a gelatin capsule or intramuscular injection once in 2 to 6 months. These are all government program in which these injections are given to those children population who are more likely to develop this kind of problem. Prophylaxis may be required in very many conditions. For example, if a patient has obstructive jaundice, have malabsorption syndrome, steatorrhea for any reason, all these or any other condition which are likely to produce vitamin D deficiency, etc. In such patient, prophylaxis is usually required, and that to ensure 400 international unit of vitamin D3 administration. Other than that, vitamin D3 is used in variety of rickets. For example, see, this is type 1 ricket. Why it is called type 1? It is also called pseudo vitamin D Okay, here actually what happens, the 1-alpha hydroxylase enzyme, because there is a mutation or it is inherited as a autosomal recessive disorder, rare autosomal recessive disorder, in which there is deficiency of 1-alpha hydroxylase. So vitamin D will not be converted into active form. So this is called pseudovitamin D resistant rickets or type 1 rickets. So we can simply give calcitriol, we can give alpha calcidiol because it's not required. They are already in active forms. So you can give normal doses of, that is 0.5 microgram to 1 microgram per day. Simply. vitamin D dependent ricket type 2. Type 2 is also known as, hereditary vitamin D resistant rickets. Hereditary vitamin D resistant rickets. This is actually because of the mutation in the vitamin D receptors. So they require high dose of vitamin D to be effective in this ricket. That is why it is called resistant rickets. Hereditary vitamin D is a true dependent vitamin D resistant rickets. This is pseudo vitamin D resistant. So that is why it is called type 1, type 2. So here you have to give oral calcitriol. There you can see the doses 2 to 6 microgram per day. Usually 0.5 microgram to 1 microgram. And renal rickets is nothing is because of the CRF. Chronic renal failure, the kidney is not able to produce produce 1-alpha hydroxylase and sufficient conversion of vitamin due to its active form. So we can use any of these. Calcitriol, that is also active. Alpha calcitriol, this does not require activation in the kidney. DHT does not require activation in the kidney. So they all can be used at usual doses to suppress, prevent development of, first of all, to maintain, calcium and all that, mineral, bone, serum calcium and phosphate level, as well as to prevent development of secondary hyperparathyroidism. Senile or postmenopausal osteoporosis. The elderly are all susceptible to osteoporosis. Postmenopausal women are highly susceptible to osteoporosis because they lose bone very fast immediately after menopause. So it is recommended that the senile and postmenopausal women, senile means elderly, male or female, anything, and postmenopausal female, they will be elderly, mean all postmenopausal and elderly male more than 70 years of age, and all postmenopausal women with osteoporosis. We should ensure that all postmenopausal women and the elderly male gets 1200 milligram of elemental calcium every day in diet. Other than that, also that 800 to 2000 international unit of calcium, vitamin D3 should also be ensured in these individuals. It has been seen when they are supplemented with this calcium and vitamin D3, the bone calcium levels are much in normal range and can promote bone mineral density or can maintain bone mineral densities in this postmenopausal osteoporotic woman and the elderly male also, right? So this is important, one should keep, but one thing one should be very careful that it prevents osteoporosis. This kind of thing can reduce, produce improvement in the bone mineral density, etc. But one should not use this if there is established osteoporosis. One should not use calcitriol, etc. We are using vitamin D3, right? Not active calcitriol, etc. Because it can lead to, immediately it can suppress, PTH level and can reduce, bone remodeling. And bone remodeling is to reduce this, then this is difficult because bone remodeling is important. Because new bone formation will happen only when there is any bone remodeling, during bone remodeling, when there is remodeling pit is formed or when there is resorption of bone, then only new bone formation. As such, alone new bone formation cannot happen. So this calcitriol will suppress this PTH activity, all these things. So this will actually lead to bone mineral density loss, in fact. However, the deficiency of vitamin D is there, suppose, that may lead to hyperparathyroidism and osteoporotic like picture. Then calcitriol can be added, but one should be very careful because calcitriol can lead to hypercalcemia, renal stone, because not only hypercalcemia, hypercalciuria will also occur, renal stones, and can lead to metastatic calcification. Metastatic calcification, the calcification in the living tissues. One is called dystrophic calcification, that occurs in the necrosed tissues, dead tissues, but metastatic calcification can occur in the normal tissues because of the excess calcium deposition. And one thing I also forgot to tell you that though I was talking about PTH, that PTH promote calcium reabsorption in the kidney and promote phosphate loss in the kidney. But when there is excess calcium, then this PTH effect will override. Then there will be these all mechanism will fail. Actually, there will be excess increase of the calcium from the kidney, because these all control will actually fall short of producing this effect. And more important is to prevent the excessive increase in the serum calcium and all that. So body overrides all these control or regulation mechanism, and there will be an increase in calcium levels, urinary calcium actually. Hypoparathyroidism, yes, we need vitamin D, because hypoparathyroidism is because calcium is PTH level is down. So what will happen? So there will not be, first of all, PTH is down, no PTH is less, so the serum calcium level will be maintained. PTH is important for converting vitamin D to active form, that will be affected. So there is, with hypoparathyroidism, there will be vitamin D deficiency will also develop. So what will happen? Overall there will be fall in vitamin, the serum calcium, etc. So we have to use certain agents that are directly active, does not require presence of PTH. Otherwise, if you give vitamin D3, that will not be active that much, because it requires conversion into 125 dihydroxy form. So which will not happen, because PTH leads to the second steps. 1-alpha hydroxylation is dependent on PTH. So if there is no PTH, then this, so we have to use drugs which are directly active vitamin D3, like DHT, calcitriol, alpha calcitriol. The calcitriol is more full active form. These are activated by action in the liver. So liver is not at fault, not a problem at all, right? So these are more effective. We, instead of using this natural vitamin D3, we should use these agents, because they are more rapidly acting, also do not require the conversion to active form, which is difficult because already PTH is low. So no PTH is required for their activation, they are already active, right? Or you can use vitamin D3, but you have to use very high doses. See, almost 1 lakh unit per day. So whatever low hypothyroidism doesn't mean that parathyroidism is there is no activity. So we have to give lot of vitamin D3 so that sufficient amount of it gets converted into, or you can use either very small doses, these DHT and calcitriol, etc. Fanconi syndrome is a disorder of the proximal tubules, which actually is not able to reabsorb phosphate. There leads to phosphaturia and also the hypophosphatemia. In that case, you can use vitamin D. Vitamin D promote absorption of both, in the urinary absorption of both phosphate as well as calcium. But PTH was causing loss of phosphate, but calcium was reabsorbed. FGF23 was doing phosphate loss, but no effect on calcium. Right? Calcitonin was causing urinary loss of calcium and phosphate both. Right? See, this is the calcipotriol, which is the calcitriol analog calcipotriol, which though it is used as ointment, it is non-hypercalcemic. But having action in the skin and all that, I told you the vitamin D receptors are present and throughout the almost on every cell throughout the body. So maybe they may have different effects in different tissues. So this hypercalcemic effect is to be separated from other effects. So this has been found to be effective in plaque type psoriasis. Parathyroid hormone. We have discussed about calcium, we have discussed about vitamin D, now we will discuss about parathyroid hormone. We know PTH is the very important stimulus for maintaining plasma calcium level, and usually PTH immediately release calcium from the bone and can normalize even immediately the ionized calcium level in the bone, in the serum. And this is achieved by increasing resorption of the bone. How the resorption of the calcium from the bone occurs, this is the most prominent action for maintaining plasma level or increasing plasma calcium level whenever it is required. This actually PTH, I told you, is responsible for conversion of osteoblast precursor to osteoclast, mature osteoclast, their proliferation, their activation. So what happens, it increases the PTH increases the birth rate of, this is called birth rate of the bone remodeling unit. Bone remodeling unit. These are nothing, these are small areas where actually the bone is dug out, a remodeling pit is formed, a kind of pothole kind of thing, and it leads to recruitment and activation of this osteoclast in these birth remodeling unit, and there it starts resorption of the calcium, because they release certain, this osteoclast release acid hydrolases and all that proteases enzymes that leads to dissolution of bone, and calcium is released from there actually. So this is the best the most important action of osteoclast. And they can also, by a direct effect on the kidney, as I said, that they increase reabsorption of calcium from the bone, increase reabsorption of calcium in the kidney. So this is another direct effect. This is indirect effect because it enhances osteoclast activity and differentiation, their and proliferation, etc. That leads to, and also it leads to increase formation of increased birth rate of bone remodeling unit. In each bone remodeling unit, increased number is there, so these osteoclasts will get recruited there and will have enhanced activity. They will try to hydrolyze all the bone tissue there, and that will release calcium, etc. But this resorption is more common when the PTH is present in high concentration and continuous action is there. High concentration and continuous action. But it also leads to new bone deposition, right? But that occurs only when it is present given in intermittently and low concentration. Then it has anabolic effect on bone. It promotes new bone synthesis. In fact, this analog of parathyroid hormone, teriparatide, abaloparatide, they are considered as osteoanabolic agents, right? In hyperparathyroidism, as I told, I was just talking last, the overriding of PTH effect. Usually PTH, what is PTH does? PTH retain calcium in the kidney, reabsorb kidney. But in hyperparathyroidism, when there is excess PTH, then it will not retain calcium from the kidney, because it will lead to then too high level of calcium in the serum. Then there will be, this effect will be overridden by the kidney defense, body defense mechanism. So the actual loss of calcium in the kidney will increase, in fact, right? And it indirectly increases intestinal calcium absorption, indirectly, not directly, because it has no action on the calcium absorption. So indirectly, because it converts vitamin D to active vitamin D3, that is calcitriol. That actually lead to increased calcium. So this indirectly increased intestinal calcium and phosphorus absorption as well. This PTH acts on the the cells through cyclic AMP generated pathway, and these are all G protein coupled receptors. So adenyl cyclase activity is enhanced by binding of PTH and all that, and leads to increased cyclic AMP formation and intracellular calcium. In the bone, the target cell is the osteoblast, because it is the only osteoblast that has PTH receptors. Osteoclasts are devoid of PTH receptor, no PTH receptor. So osteoblast, PTH control activity of the osteoclast through osteoblast, because osteoblast has PTH receptor. So PTH can stimulate formation of osteoblast from the pre-osteoblast, and also induce production of, I told you, this protein rank ligand RA, which actually binds with osteoclast precursor and convert them into mature osteoclast, and this osteoclast in the have this receptors rank, and this is the ligand, and this osteoclast in association with that is called monocyte colony stimulating factor. Along with that, this leads to engagement or recruitment of these osteoclasts in the this to improve resorption and all that. So there is increase in, actually ultimately on the bone, they lead to increase bone morphogenic unit, that is called, or remodeling pit, bone remodeling unit also you can call it. So they increase resorption. And just remember, new bone formation will only occur at the site of resorption. It will not occur on a normal bone. Remember this thing. That is why PTH activities was equally important. It is not only, so osteoclasts are equally important. Got my point? Because osteoclast activities are continuously, suppressed by bisphosphonate compound which we used in osteoporosis. They have many, side effects like osteonecrosis of the jaw. They can have, fracture of the trochanteric, subtrochanteric fracture and all that. That is the result of the over suppression of the osteoclastic activity. So remodeling is an ongoing phenomenon. So it keeps happening every time. So new bone formation will only take place when there is a resorption. First, there should be a resorption. There should be a bed should be created by removing old bone. Then only new bone formation occurs. But I told you this PTH at low dose and if given intermittently can promote bone synthesis, and a higher dose, continuous level, continuously higher concentration and continuous presence will lead to bone resorption. Affect pre-osteoblast. I told you this vitamin D and PTH both can convert pre-osteoblast to osteoblast, and osteoblast is important for formation of osteoid. Osteoid is, I told you, this protein part of the bone which was being catabolized through steroid, etc. I told you indirectly loss of bone they can lead to, because osteoid is damaged. Osteoid is actually mineralized, right? So along with, if osteoid is degraded, along with that the mineral will also be lost. So this osteoid is mineralized. So this osteoblast lead ultimately affecting pre-osteoblast. Osteoblast is formed. Osteoblast leads to this available production of osteoid, and this osteoid will be mineralized later on. Actually, the vitamin D is more important in ensuring that the levels of the calcium and phosphates are sufficient at the site of new bone formation, so that the proper mineralization can occur, right? So I told you the new bone formation occurs when the concentrations are low or are intermittent, and resorption predominates when high concentration present continuously. And this has been exploited in the therapy of osteoporosis, this particular phenomenon. What are the uses of parathyroid hormone? Obviously, the hypoparathyroidism as a replacement therapy. So recombinant human PTH. PTH is 84 amino acid peptide. It is a full length human PTH similar to recombinant human PTH. It is used in adjunct to calcium and vitamin D to control hypocalcemia. Because in hypothyroidism there will be hypocalcemia. In hypoparathyroidism we are using vitamin this directly active vitamin D also. So here they are using this recombinant hormone PTH. Okay, but when you are using this treatment is to be reserved only for patients who have not been adequately controlled on calcium and vitamin D alone. then we have to use recombinant hormone PTH, because this is associated with the risk of osteosarcoma. Got my point? So this is to be used, in the doses of not to be more than usually used 50 microgram subcutaneously, right? And then we can gradually increase every 4 weeks by 25 microgram, and it should not be more than 100 microgram. And if despite 100 microgram, if the persistent, you are not able to maintain the serum calcium level more than 8 milligram percent, you can go up to 100 microgram, but not more than that. But if at this dose, starting dose, somebody is maintaining plasma concentration more than 9 milligram percent all the time, so you can reduce the dose to 25 microgram per day. This caution is required, as I told you, that there is a risk of osteogenic sarcoma. We have other agents also to control or treat this hypoparathyroidism. Yes, this hyperparathyroidism. Calcium mimetic agent. Calcium mimetic, they actually behave as calcium. That is why they are called calcium mimetic agent. This senacalcet. Actually, on parathyroid gland, we have this receptors, calcium sensing receptors. This is nothing but G protein coupled receptors. So this senacalcet these are substance which actually binds to modulatory site, not at the PTH binding site. Calcium binding site, because they sense calcium. So not at the calcium binding site, at some allosteric site other than calcium. Because if they bind to the calcium site, how they will improve sensitivity of these receptors to calcium? Ultimately, calcium has to bind to these receptors, but this senacalcet actually improves the sensitivity of this receptor to provide a given level of calcium. Now these receptors are more sensitive to the inhibitory action of calcium. Similarly, when benzodiazepine binds to allosteric site of the GABA A chloride channel complex, first of all it improves, increases the affinity of the GABA to bind with GABA receptors, or also allostatic modulator is such that it increases the frequency of the opening of the channel induced by GABA. Got my point? And in absence of GABA, benzodiazepine does not have any effect. So similarly, in absence of calcium, these will not have any effect. So they bind to a modulatory site, or that is called allosteric site, and modulate the receptor in such a way that it becomes more sensitive to action of the calcium. So when calcium binds, the hormone, the gland is suppressed or inhibited more strongly, right? So the increased sensitivity of calcium sensing receptor is used in hyperparathyroidism. Primary means there is some adenoma or something which is releasing this PTH, or secondary hyperparathyroidism that usually occurs in CKD and dialysis. I told you why it occurs, because there is vitamin D deficiency. Vitamin D deficiency is the calcium is decreasing, and inhibitory effect on the parathyroid gland is also reduced, so that can all lead to secondary hyperparathyroidism and hypercalcemia in patient with parathyroid carcinoma that is associated with hypercalcemia that can produce PTH and all. Evocalcet is available in Japan, and it has equivalent efficacy to senacalcet and at lower doses. But there are many gastrointestinal side effects associated with senacalcet that actually impairs the long-term compliance of the patient, and also the reduced efficacy because of this side effects. The increasing dose is difficult. So this evocalcet has improved bioavailability. So lower doses are effective and have minimal GI side effects. So this has been approved in Japan for secondary hyperparathyroidism in patient dialysis, but not in US or UK. Aticalcetide is another compound which is also used in SHPT in CKD with hemodialysis, chronic, that is in secondary hyperparathyroidism. This is also a allosteric modulator. All should be allosteric modulator of calcium sensing receptors, but it is not metabolized by CYP enzyme. This is the peculiarity of this. It is metabolized directly by reversible disulfide exchange, right? and it is usually given 3 times in a week. Usually we they undergo dialysis 3 times in a week, so one can start with 5 milligram and can increase in the incremental doses every 2.5 milligram every 4 weeks, and can go to maximum 50 milligram per dose. The doses may be increased up to 3 times depending upon the response, but the increase should be made in the small incremental dose is there, 2.5 milligram every 4 weeks. So you will take at least 24 weeks to reach 16 weeks to reach 15 milligram dose. So maximum we can use 45 milligram per week. These PTH as such is not used in osteoporosis, but it's 134 residues analog. The actual why this teriparatide, it is called recombinant PTH. It is not similar to recombinant PTH, human PTH, that is 84 amino acids recombinant. Actually it is only 34 amino acids from the amino terminal. Only 34 residues, because these 34 residues have the full activity of this 84 amino acid. This rest 50 amino acids are useless. This 34 has capable of binding to the receptor, showing all the activity of parathyroid hormone. So binding to the receptor actually is important, is 1 to 21 amino acid, and for activity 22 to 34 is responsible for activity. So it is given in a very small dose. You can see 20 micrograms subcutaneously per day. Usually parathyroid have half-life of 4 minutes, but this has half-life of around 1 hour. So in these doses given once daily produces intermittent and low concentration. So it acts as a bone forming compound. It promotes bone formation. So it is actually indicated for treatment of post-menopausal osteoporosis. Those women who are at high risk of fracture should be at the high, not only just osteoporosis, at high risk of fracture. Similarly, primary osteoporosis or hypogonadal osteoporosis. Primary means with the age there will be loss of bone with time, and hypogonadal osteoporosis. Some men who are hypogonadal, so they develop because of the this testosterone level deficiency. They are at an increased risk of this bone density, because ultimately in men also estrogen is formed, that is derived from androgen. So if gonads are not working, then there can be osteoporosis and all that. So they are also should be at high risk of fracture in man. So these two are the indication. Another indication is glucocorticoid induced osteoporosis, who are at increased risk of fracture both in man and women. Glucocorticoid can be used by any man or woman, any. So these drugs, as we say, they promote bone synthesis. So it is always said, whenever you are treating osteoporosis, always use bone promoting agent first, and then you can use the drug which is anti-resorptive, which does not promote bone synthesis but prevent bone loss, like bisphosphonate, estrogen, all this denosumab, etc. So they can maintain this increased bone mineral density. So this is sequence should always be followed. Whenever you always give this bone formation bone synthesizing or bone formation promoting substance first, followed by anti-resorptive agent, which are BPN or estrogen or denosumab, etc. These teriparatide, and another agent is called abaloparatide. These are named as osteoanabolics. This term you should know. This actually parathyroid hormone have two kind of receptors. So this teriparatide and abaloparatide acts through receptor type 1 PTH type 1 receptor, PTH 1 receptor. This receptor is also, as I told you, this PTH receptors are G protein coupled receptors. G protein coupled receptors are divided into many families. A to F. This fall in B. This is, family B, which is similar to secretin hormone family. A is most common type of G protein couplers. They all fall in this, and rhodopsin that is present in rod cells and etc. That those receptors are also the family A, right? Now this teriparatide is, I told you, the N-terminal side 1 to 34 amino acid. But along with that we have parathyroid recombinant, I show you this related protein, human parathyroid related protein, parathyroid hormone related protein. Abaloparatide is first 34 amino acid peptide analog of this protein, not PTH, PTH related protein. But there are some difference, I tell you. This teriparatide, this GPCR, that is, I will call PTH1 receptor, it exists in two conformation, R0 conformation and RG conformation. When this is stimulated by PTH, the RG conformation, if stimulated, it will have this short lasting effect, more pronounced but short lasting effect. But when R0 conformation is stimulated, it will have less pronounced but more prolonged action. Got my point? Now this teriparatide has this abaloparatide and teriparatide both have similar efficacy for affinity for RG conformation, similar affinity, same affinity. But this teriparatide has 4 times more affinity for this R0 conformation. So you can see it actually leads to, and the response is because of the increased cyclic AMP release. This leads to calcium level and etc. Increase intracellular calcium and all that. So here, what changes, this difference could be achieved because this and moreover this has high affinity, and this actually dissociates faster also from the receptor. First of all, it has similar affinity for both, but it dissociates faster. But this remains bound and more affinity for this, which actually produces prolonged action. So initially what this teriparatide, it actually causes anabolic effect on bone, increase bone production. But because of this action, what happens, this therapeutic window during which it produces anabolic effect on bone is small. Why? Because I told you just now that PTH leads to increased production of rank ligand from the osteoblasts also, and this rank ligand bind to osteoclast precursors, and osteoclast precursor it's converted into osteoclast, that they lead to resorption and all that. So this anabolic effect is limited by, or with time actually fades off, and this osteoclastic effect or resorption effect becomes more important because of this differential in affinity, differential receptor affinity. But abaloparatide being, first of all, it has similar affinity for both, dissociate immediately, does not remain attached to the receptor, and this is also the hormone is more stable. It has half-life of 1.7 hours. Here what happened, first 21 amino acid of this abaloparatide is important for binding to receptor. That is fine, same, this is binding. Another 24 to 34 amino acid, there are several substitution of amino acid has been done. Amino acid substitution has been done in abaloparatide. So this has led to the improved stability of this peptide. That is why abaloparatide is considered as, because this does not lose this anabolic effect for a long time. This therapeutic window is long, not small. Got my point? So abaloparatide is an improvement over existing teriparatide. Got my point? But it is not PTH analog, it is analog of PTH related protein, right? And treatment same at women at high risk of fracture. So we will give 80 micrograms of protein per day. It has half-life of 1.7 hours. This also produces, intermittent and low concentration, and it is also approved in women who have failed to or is not tolerating the existing therapy like estrogen or the bisphosphonate, etc. These bone promoting substances, synthesis abaloparatide and peritide, both reduce risk of vertebral and non-vertebral fractures. Estrogen affects more the vertebral fractures. Both agents stimulate bone formation, but it is, in fact, they were considered as the only substance which produce bone formation. Rest of these bisphosphonate, estrogen, and other raloxifene, etc., they are all actually anti-resorptive. They prevent loss of bone. They do not promote bone synthesis. But now some of the BPN have been found to promote bone synthesis also, like alendronate, zoledronic acid. They have potential to promote new bone synthesis also. So usually it is said that the sequence of administration should be maintained, that first bone synthesis promoting substance should be used, followed by anti-resorptive agent. So we should ideally we should give these substances for 2 years only, because there is a black box warning associated with teriparatide that is associated with increase in osteosarcoma risk. So whatever bone synthesis has been improved, bone mineral density has been improved by these agents, that can be maintained by use of anti-resorptive agent. Then we should try bisphosphonates. If you have already you are trying to use both the agents, so first use this bone synthesis promoting substance. And when there is severe osteoporosis, we can use this bone promoting substance, as well as the abaloparatide should be added with denosumab. That is the monoclonal antibody against rank ligand. Means whatever rank ligand is secreted because of the action of this abaloparatide and etc., that will be bound to denosumab. It will not be able to act on osteoclast. No action on osteoclast. So we have now double therapy, means we are promoting bone synthesis also and preventing resorption also. So the effect of the combined therapy is always higher than the single therapy, right? And both in given once daily basis, so it ensures that there is intermittent action and the concentrations are low, and no more than 2 years continuous should not be recommended. As I already told you, there is concern, that is black box warning associated with teriparatide, that it can cause osteogenic sarcoma. So once after 2 years the treatment is completed with then bisphosphonate initiated to retain improved BMD, may be administered with denosumab. I have already told you this is a monoclonal antibody against rank ligand, right? And the combination is always better than this adjuvant therapy. And anti-resorptive therapy always be given after the course of PTH, that is peritide or this is abaloparatide, right? Along with that, the supplemental vitamin D3 and calcium with any therapy of osteoporosis. One should ensure sufficient supply of the elemental calcium as well as vitamin D3, so that the effect of the drug should not suffer because of the deficiency of these two compounds. They should always be supplemented in treatment of osteoporosis. Women are more prone to osteoporosis. You remember this axis. Axis leads to osteoporosis. What is axis? This axis is different, meaning it's not excess, but it has some meaning here. That's alcohol use, corticosteroid use, calcium low, estrogen low, and smoking and sedentary lifestyle. So 2 S is for smoking, sedentary lifestyle, E for low estrogen, C for calcium low, C for corticosteroid use, alcohol use. So these all can lead to increased osteoporosis in women. though they are as such otherwise more sensitive, susceptible to osteoporosis immediately after menopause, because bone loss is maximum immediately after. So any such therapy should be initiated within the first 5 years of this menopause. So guys, this was the first part of the bone mineral metabolism drugs or hormone affecting bone mineral homeostasis. I hope that you must have liked the class. I have explained everything with diagrammatic support, as well as I could explain as much as possible so that the things get inside your head as much as possible. Guys, you have this, get this app, Telegram app, and join this group so that you get all the notifications about the class, etc. So it is always good for you to have this app and receive notifications so that you can plan your timetable as per the schedule we share with you. We have already discussed the advantages of this paid premium service, which offers a lot many things which other platforms do not. Especially the Unacademy is good in the sense that it has provided more than 80% of its things free of cost to help people, and they have a democratic way of giving education to, or deliver higher education to individuals like you. So you should make use of those free classes and all that at every platform. But this is a premium service which offers a little more than all these free contents. The classes are same, but the facilities that it offers is much more than what you get on the free platform. Like here, the classes are more interactive. You have more opportunity to interact with educators. You can keep asking your doubts, keep clarifying your queries, etc. There is facility of polls and leaderboard, which is not otherwise present. You have the study material all, because in other platform you can only attend classes, but study materials in the form of test series, quizzes, and their analysis, etc. is all available on the. And as I said, these classes are more interactive, so you have much opportunity to clear your doubts, everything, and the access to all the contents available at is unlimited. You can download any video, you can download any notes, and as many time as possible, and you can read them offline whenever you feel like. So it have simply made your life little easier. And the quality of the stuff present on the site, that is the test series, etc., are definitely really very good quality material that would definitely help you improve your standard, or your knowledge, understanding about the subjects and all that. So it is one-stop solution for all your needs. So I would rather suggest you guys to try it once at least, and just experience the the benefit that it offers. Enjoy those benefits, though it comes at a cost, but it's worth paying for this subscription, because unless you taste something, you can't say that whether it is good or bad. Guys, there is another app that is launched by Unacademy, where you can attend other free classes in the form of special classes. They are available as special classes. So I teach at every platform, right from special classes to NEET PG live daily, also on Plus. Like on YouTube, I am talking about the endocrinology drugs. And on this Unacademy learning app, in the special classes, I am talking about antimicrobial agents, and on Plus I am talking about the drugs affecting central nervous system. So I talk on every platform. If you like my classes, you can follow me everywhere. So but on Plus you have to be subscriber to that, then only you can attend. This special classes are different from YouTube classes in the sense that it gives you an opportunity to interact with educator. This is one advantage. Second is if you follow me on this platform or on this app, you can send me direct message. So you can share with me your queries, your doubt, not only from special classes. If you if you watch my lectures on the YouTube also, the question related to those lessons also can be asked, can be put forward to me. I would definitely reply back to you. And this special class interference this interface is such that you will definitely like it. It is very similar to Plus. This is a kind of platform which gives you a feel about the Plus, and Plus of course has much more to offer than these special classes. That is why if you don't have this learning app, you can download it as much as early as possible, and tell your friend also to download it and take full advantage of this free portal. If you have decided to join this Plus, and you want to be part of that Plus, then you have to go to this manage goal category, under which you have to select NEET PG, and under NEET PG you have to select Plus, and then you have to get subscription. If you have any doubt, you can talk to this Unacademy guys. They will dispel all your confusions or any kind of apprehension you have. And this available for this subscription is available for right from 1 to 24 months, which I have told you already in the beginning. But we always prefer that one should get associated to NEET PG for at least 12 months, because to get it to get everything properly or learn things properly, you should remain associated for at least 12 months. Because if you keep hopping from one place to another for a month or so, that is not going to solve your problem. And anybody who actually subscribe for 6 months or more than that can avail facility of no cost EMI, etc. 24-month subscription is good for those who are UGs guys. They are already in geared up for PG preparation and all that. But you can cut down the cost of the subscription by just using this code, this referral code of mine. This will, at least it will not reduce your load too much, but it will definitely reduce it by 10%, and that is not a small amount. So similarly, whatever period you choose, but though we have mentioned it for 12 or 24 months, and that is very much required. In fact, we always recommend that at least 12 months subscription should be there, so it will reduce the financial load by 10%. So guys, keep enjoying this NEET PG, but you have all subscribed. If you know some of your friends, those who have not subscribed to it, ask them to subscribe. You just click this bell icon so that you get notification if there is something new on this. And if you can share with your friend the link of this, if you follow it, you can share the link of this lecture with your friends and all that, and ask them to subscribe also. And it is anyway not going to harm you. It will definitely will benefit you in all aspects. And if you liked my lecture, give a thumbs up, and definitely share it with your friends. Share it with as many as people you can, those who actually need it, and tell them also to join or follow this particular NEET PG channel on the YouTube. This is the last suggestion that whenever you want to join, because the subscription is open for every time it is open 365 days, and using this code will definitely cut down the financial burden by 10%. That is also, it's good, at least is better than nothing, so just use this referral code when you have planned to join Plus. And with this, half of the topic is covered. Another half I will be talking about about drugs available for osteoporosis and all that, bisphosphonates, etc. There are a lot many things have been left that will be covered in the next half of this topic. So this is all which I wanted to share with you, and you can go back and read it a little more in detail if you want, and just